can start the session now. Call the panelist for a CapsuLaser, Dr. Aditya Kelkar. I saw him, he's there. Dr. Manpreet Kaur. So be in the front row, please. Let's start with the first speaker. If we know that David is here. How does capsular help in a cataract surgery? Capsular? CapsuLaser is not completed. Okay, how does it help? Let's have David talk about this.
Great, good afternoon everyone.
I request people to come inside, don't block the road because we have a very narrow entry and exit. Please come inside and take the seat. Thank you. David, all yours.
All right, great. So for those that don't know my background, I've been involved in ophthalmic lasers since the late 90s. So SLT lasers, Pascal, Visidyne, femtosecond cataract are all things that I've been involved in from the very beginning and invented many of those. This actually follows the experience of femtosecond cataract and basically looking for a more economical approach that also could provide benefits in complex cases and also just work with the workflow. So not to take up so much spaces, resources, electricity, and everything else that we just heard about in the green revolution that we're all going to have to face. This is real time. These are capsulotomies that take a third of a second. So why should we consider CapsuLaser over other technologies? So first, it is superior for complex cases. So we can see this in intermittent cataracts, pseudoexfoliation, pediatric, and we can go on. The high tear-resistant edge really transforms the capsulotomy over other technologies, such as manual or femto. This is much stronger, and I'll go through this. The trypan blue needs to be present because the laser interacts with trypan blue. When we did femto, the capsule is clear. When we do manual, the capsule is clear. And the way that I made CapsuLaser work was by just saying, let's look and see what Dork did, and we can do better, and our dye is indeed better. But now, once it's stained blue, we can now actually create an orange laser to interact with that. And then we get the visibility throughout. We'll touch briefly on centration. And then for my colleagues that are in Eastern Europe that see a lot of intermescence, they're reporting back, they have seen Argentinian flag sign disappear. 0. I'm sure we're going to find it in India because we see very much more mature eyes. So I'm going to say minimal occurrence of Argentinian flag sign. And the real benefit is here is that we are non-invasive with the laser. With premium lenses, or in fact all IOLs, we actually can see improved outcomes. And how can this be the case? If we get complete symmetric 360-degree coverage of the IOL with the capsulotomy, our effective lens position is exactly what the biometry calculations are showing. If we are asymmetric, or if we are not got 360, then you could throw your biometry out or add some unpredictability to it. So by having 360 coverage, we're seeing incredible predictability in uncorrected distant visual acuity. And I'll show you some of the initial results on this. Finally, we all know that fellows find it hard to pick up the technique of manual capsulorhexis. And we can actually do, by design, a partial capsulotomy that then a fellow can come along and now engage in the technique and then also has that hard, strong rim as a safety net. And then if you go outside of that, then everything's trypan blue. So there's many potential advantages. So let's go through these 3 different scenarios. So the strong capsulotomy edge, we see a cadaver eye here, lens capsule. The dark blue edge is indeed the capsulotomy. And we can see it stretched almost what would be white to white. If we look at the strain gauge calculation here, we can see that 5 millimeter capsulotomy is stretched to 12. But if we were doing, before it ruptures, but if we were doing manual, it would only stretch to about 10. So these are the strain gauge curves that are based upon the measurements. We can also see this in vivo, in the OR, in real live eyes. This is Burkhart-Dick. And then basically, we see the relative strengths that are reported in the journal, British Journal of Ophthalmology. And what is this dark blue edge that gives us the strength? This This is a scanning electron microscope that shows the rolled over edge, that gives us the strength, very much like we have with clothes. If we have a rolled over edge or a hem, then it basically does not show a defect, and so therefore it's inherently much stronger. So this is what we want to avoid. Why does Argentinian flag sign occur? Because there's contact. The other great thing with CapsuLaser is that we can have OVD in the anterior chamber so that we can counterbalance pressures, so we can use all the great techniques that are out there. We don't have to make an initial small capsulorhexis. We can just come along with a laser and then basically create very nice capsulotomies. And you see the difference in sizes here. This is because there's a high pressure. Let's just go through a couple of extra ones from around the world. This one's from Spain. This one is from Saudi Arabia. We'll go through this a little slower. You can see the incision's actually very small where we make it, but it opens up with the pressure that's involved there. And then we'll go to the, just a moment here, we'll jump to the phaco whilst we slide the laser out. And what we'll see is the eye has a lot of milky fluid there, and as we come along, we can aspirate that away, showing that truly was the pressure that was built up there, and a very intumescent cataract. And as we know, the nucleus is not so hard once we've dealt with that pressure and the thin tissues. Now this is from Brazil. We basically, very similar, intumescent cataract. And you can just peel off the capsular disc. Now interestingly here we say, oh, there could be some bridges, but no, there's actually fibrosis occurring underneath the capsule. We see that because we have the trypan blue stain. And so now we don't get surprises when we're doing phaco, and we can now just come along and just peel this off, or try to peel it off, and decide, and again, the strong capsular rim helps us here because it adds a lot of strength. So something that, and now this is just a normal cataract, so we wouldn't have any issues there. Pseudo-exfoliation patients, small pupil, thin tissue. We can just dial in the size of the capsulotomy as needed, or use pupil expanders. Again, we have access to the anterior chamber to really maximize the pre-capsulotomy conditions. I have a minute left, so let's go. Pediatric case, just to show you, as we know, they expand, so we can cut at 4.2, but we see rather large expansion up to 5, so let me just put it this way. 4.5 gives you 5.2 millimeter diameter. So you want to cut a little small, but not 80%. Probably around 85% is where we see with pediatrics. So this is what we'd all like to see in premium cases, but we may be able to see that in all cases. We can see the Purkinje images where the patient's fixated. We see a dark area actually centered on those Purkinje images, and that's a trypan landmark. And then we see the capsulotomies below. If we center on the Purkinje image or that dark blue area, the trypan landmark, we get excellent centration. And we can see this is verified by Zeiss-Callisto overlay reference to the IOL master data. So we see excellent correlation on the central axis, and that central axis seems to be key to giving us great centration of the IOL in vivo. And if we compare it to Victus, we can see that some of the femtos are not, let me just say this, not all femtos are the same, and I've developed some of them, so I know. And I'll actually say Catalyst is very good at centration. But we know Victus and Lens X may not be so great. And for example, in this image down here, we can see that we are asymmetric, and we probably actually have zero coverage over here. And that's going to be a tilted lens, and you can even see that in the Purkinje images on the lens. Very interestingly, if we now look to how predictable the distance visual acuity is, we can see if we compare asymmetric coverage of the IOL to symmetric, we actually see here, in this column here, a difference in uncorrected distance visual acuities for the same IOLs. Yes? Okay, it's all right, I'm nearly done. I've got 0 time left. For the next speaker, maybe. So here we see an anterior fixated capsulotomy basically occurring. So again, capsule laser, very robust capsular rim, can be manipulated very easily. And so here we see, as I said, an anterior capsule fixated lens, or a femtosecond lens in this case. And there are several other companies coming out with this. The anterior position of those IOLs removes some dysphotopsia. And of course, having it centered and a robust capsulotomy of the correct size and circular is critical. And for example, in Australia, we are 100% of the largest femtosecond lenses being used, and we are in every single OR, and they're all created without laser. Just to show you the idea of accelerating manual capsulorhexis training, this is by design. So we actually use the same laser, same setup. We use a different OVD. This OVD will actually scatter the light a little bit more. And what we can see here is that there are bridges, but it's relatively consistent. And it's actually only about 20% remaining of the capsule. 80% has been essentially separated. So now, this will be great for a fellow to come in and do training and basically move forward, and then just manually, after doing their OVD fill with their preferred OVD, you can now just come along and just manually do a rhexis, and it's going to be great for training. And you have a strong rim if they go a little bit too aggressively, really working on the tangential motion rather than the radial motion. And just to summarize, superior for complex cases. The strong rim and visibility really enable that. Premium lenses, the predictability comes about from the 360-degree coverage, and that really goes to all the biometry calculations, and then accelerated training for manual. So that's why and where we can use capsule laser in cataract surgery. Okay, thank you.
Thank you very much, David, for highlighting the advantage uses of CapsuLaser. Now we invite Dr. Kelkar, who's taking us his first encounter with this system. Dr. Kelkar.
So this system was introduced to us about 3 months ago, in fact, as a demo unit which we have. And then we purchased it within a few minutes. So basically, this is a very smart laser which works on a dye, which stains the capsule. And so it looks relatively simple. However, the attention to detail is a must. And you must understand that it stains the capsule. The dye stains the capsule, and only when the dye is uniformly stained, you will get a good uniform capsulorhexis. So I'm going to share with you some of the initial cases. Some of them are simple ones, some of them are actually complicated, and some I have managed to make them little complicated. So as you know, it's not exactly a capsulorhexis, but it's a capsulotomy, selective laser capsulotomy. It finishes its capsulotomy within 1/3 of a second. So this is a routine cataract surgery case. You can see a well-stained capsulorhexis, and there are no hurdles here. And you can see a well-centered 5 to 5.5 millimeter capsulotomy. this initial experience, we start to get a little bit more adventurous. As you can see here, this is a patient of mature cataract, and I thought maybe I'll have a good 6 mm capsulotomy. Unfortunately, one of the edges crossed over the incision, and therefore I have a small capsular tag, which did not matter because I could easily remove it using the forceps. We've recently done a small study on Indian eyes with mature cataracts. About 30 patients were included in this study, and we have seen that the 360 degrees capsulotomy was achieved in all the patients, and 5 to 5.5 millimeter capsulotomy size was achieved in all patients, which remained constant at the end of 3 months. You can see this anterior segment OCT scan. And we also did the endothelial cell count, and it's same as any other cataract surgery or femtosecond or phacoemulsification, about 8% cell loss. Thank you.
Thank you, Aditya,
Thank you.
showing so many good pictures.
Thank
Just one question, what type of dye do you use and how long it has to be used so that you get a
Yeah.
very good staining?
Yeah, so this is a special dye, which is of course the blue dye manufactured by the same company, and it's 0.4 milligrams, and it has slightly heavier consistency, so it stains the capsule uniformly. It settles over the capsule much better than the conventional dye that we have.
Okay. So it's been provided free of cost by the company?
Not at all.
Thank you, Aditya.
Thank you.
Let's invite Dr. Manpreet Kaur. She's going to take us through her experience initial experience with these CapsuLaser.
Thank you, sir. So I'll be presenting on CapsuLaser my initial insight. At the outset, there are no financial disclosures. So continuous curvilinear capsulorhexis, we all know, is a prerequisite to achieve optimal outcomes. In fact, the transition to phaco was marked from going from manual capsulotomy to a continuous curvilinear capsulorhexis, and of late laser capsulotomies are in vogue. We have femtolaser, we have Zepto, and now we have CapsuLaser. So what's the mechanism of action? The trypan blue stained capsule absorbs the orange wavelength laser energy, and the type 4 collagen of the capsule is converted to an amorphous collagen. So photocoagulation is the mechanism in this as compared to a photodisruptive laser as in femto. So this is just a case, one of the initial cases that we tried. So as per the company advice, we did stain with a trypan blue dye provided by them for a total of 1 minute. So after 30 seconds, you have to inject a small amount of BSS. It helps in more uniform staining. Air bubbles should ideally be avoided because they do interfere with the uniformity of staining. And make sure to wash the dye thoroughly because the orange laser is going to be absorbed by the dye. So you don't want any aberrant staining, and you want a uniform capsular staining. OVD is then injected, and typically you should slightly overfill the OVD. After you have filled in, we usually use a 2.2 incision to inject the OVD, and then the paracentesis to inject slightly more so that there's a slight overfill, which will lead to a flattening of anterior capsule. So as flat an anterior capsule you have, the more uniform would be the laser application and less chances of tissue bridges. Centration is not pupil-centric. You have to center on the Purkinje images. This fixation ring aids in centration, or the trypan blue landmark, as is said. So the cross, as you can see, these two lights, we are so used to the laser system, you have to align all the lights. These have to be apart, and the cross has to be there, which changes into an inverted V configuration when you place the fixation ring. And these two lights should not coincide. So it's a less than 0.3 second capsulotomy procedure. It's over in the blink of an eye when you press the foot pedal. You can alter the size of capsulotomy as well, till up to 5.5 millimeters. So initial cases, we did have a few tissue bridges. So I had a habit of going in with the TOMI only to just release those bridges and then gently pull towards the center. This had minimal bridges. So once you gain experience, you can go in with, I prefer a TOMI to release those adhesions. You can use a forceps or any other device. Subsequent phacoemulsification is uneventful. You can do a normal hydro procedure. So So as in femto, whenever you used to make a capsulotomy, you know that hydro is not the same as it is in if you are doing a phacoemulsification, because the cortical rim is also cut with the capsule, so you cannot really go a clear cortical cleaving hydrodissection. Similarly, this also has a slightly different behavior than a normal phaco, but otherwise it does not interfere with pre-rotation of the nucleus or subsequent nucleotomy. So the capsule is of course resistant to all the normal phaco maneuvers. It's quite strong. Unless you have tags, that can be a potential source of weakness. So after that, we'll implant the IL. Sorry. Can I have? Yeah. So I'm also removing some of the remnant cortical matter after implanting the IL. I'll be polishing the anterior capsular rim slightly, and you can see that these maneuvers have no adverse impact on the capsulotomy edge, so it was quite strong. So in a premium IL, this is a case of a premium IL, what you look for is ideal centration and ideal coverage, and both could be optimally achieved in this case. So you can see a well-centered IL with the Purkinje images right in the center and a perfect rhexis-tomy. So the customizable capsulotomy diameter ranges from 4 to 5.5 mm in 0.1 increments. So we aim for a 5 mm capsulotomy for 360-degree coverage of IL optic, so that 0.5 mm is left all around for a 6 mm conventional IL optic. Significance, it helps in centration and prevention of PCO. So what I realized was when we did a 5 mm target capsulotomy, so when I put the images in ImageJ, I found them to be smaller than my usual. So it was leading to a 4.08 mm capsulotomy diameter. So I increased it to 5.3. So what I ended up with in a 6 mm optics was 4.48. So maybe it has to do with the amount of OVD fill, some centration changes in hands, in different hands, but I preferred a larger capsulotomy to achieve the size that was my usual with a manual continuous curvilinear capsule rhexis. Then centration and focusing Purkinje images and trypan capsular landmark are used. So this is before the fixation ring is placed and with the fixation ring. So maybe since there is a variability in the amount of, there is a laxity that you can go from the cross to this, both are correct. So maybe this does impact capsulotomy size as well. Centration was perfect, as you can see in these post-operative images. Strength, of course, it has already been covered by Mr. David, that strong capsulotomy edge is resistant to tearing. Microadhesions of note are a potential point of weakness from where the rhexis-tomy may extend. But as you can see in the case, they're highly resistant to polishing. So this is a case of intumescent white cataract. So this is where I really found an advantage of the CapsuLaser. So after a uniform staining, OVD fill, so what we have is a fluid release in these white cataract cases. So this is a fluid-filled liquefied cataract. As you can see, there is no burst of fluid that occurs or a sudden egress that we have faced even in flax. So there's a slow release of fluid going on. So this was really a very beautiful thing that I observed with CapsuLaser, that it's allowing a slow release of intralenticular pressure, and as you can see now it's fluid filled. So I did go in with a tomy to see if there is any residual micro adhesion present, but the slow release of fluid is where this CapsuLaser is really beneficial. So as you can see, the capsulotomy was complete all around. So I was just using this tomy needle as a precaution in case any tissue bridges remain. So there were some microadhesions, but no tags per se remained once I had removed them. So if you look at flax, there's a burst of fluid when the femtolaser is applied. In contrast, CapsuLaser gave a beautiful, slow, sustained release, was over quickly. So this is one area in which I think it has a definite potential advantage. So in a case of intumescent cataract, it does fare better than all other methods. So coming to just summarizing my initial insight, Anatomical parameters, circularity was perfect. Continuity, tissue bridges may be due to improper focusing, the initial learning curve, areas of fibrosis, scarring are easy to release. Centration is perfect, strength of the edge, it's stronger than CCC unless you have micro tags, etc., in which you extend. Size, in my experience, 5.3 to 5.5 mm for target, 5 mm capsulotomy may be better. Ease and time, excellent ergonomics, fast, comparison with other laser capsulotomy. So flax now is advocated that it's basically good for capsulotomy, and for incisions and nucleotomy per se, the advantage may not outweigh. So in that case, a portable device that's attached to the microscope itself may incorporate all the advantages of laser systems without any potential extra cost or disadvantages. Cost effectiveness, of course, is there. It's a portable single-time laser system. Thank you for a patient hearing.
Thank you, Manpreet, for highlighting all these things. I think this is a device which may make the life simpler for our phacosurgeons, where you need to have a perfect central opening in the anterior capsule. As she summarized towards the end, again, I'll ask the question to all three of you. You have access to a femtosecond laser device and you have a CapsuLaser. Which one to prefer now? Adit? CapsuLaser. Manpreet?
Both have their potential advantages and disadvantages, but CapsuLaser is a nice way to go. Yeah.
Okay. David has a different opinion.
So I think that definitely in complex cases it shines, and you can see the strength really bear out. It's continuous cut has a lot of benefit.
Yeah.
So, and then I think the
मैं आ रहा हूँ,
centration
ठीक है.
is the other trait that femto really haven't got.
नहीं नहीं अभी पहले ही चल.
So that's some have got it right,
हाँ.
some not. So that will play out if you start looking at it.
Okay, I think we are getting late. Sorry, we can have a discussion later. Let's go into the next session. I think next people or panelists, we have Dr. Radhika Natarajan, Sheetal Barar, and Pooja Khamer. We'll be doing the next thing. I'll invite Dr. Radhika to start the presentation and to take the chair also for a discussion.
I think I'll invite Dr. Supriya Sri Ganesh. She also is going to share her experience with CapsuLaser in her practice. And Dr. Supriya.
So I tried the new CapsuLaser system for laser cataract surgery. This is a compact 590 nanometer solid state laser that can be directly attached to the microscope. Unlike other femtosecond lasers, this has virtually no footprint in the OR and allows for a single step procedure. The capsule first is stained with trypan blue dye and then the laser is slid into position. Using a separate foot pedal, the laser is centered, focused on the anterior capsule. The rexus size can be selected anywhere between 4 to 5.5 millimeters. There's no patient interface or any suction on the eye. The laser takes just 1/3 of a second to fire. Wait for it. That was the laser. That's again in slow motion. And that circle you can see in the eye is the well-centered laser capsulotomy. The laser is then conveniently moved out of the way. The capsulotomy is supposed to be a free-floating one. That's the hydrodissection, and you can see that there are no tags there. The edges of this laser capsulotomy are meant to be stronger than a manual rexus or a femtorexus.
So that was just a quick video of an initial experience with the CapsuLaser. So as you can see, it has a very small footprint in the UI. You can attach it directly to the microscope. That's the main advantage of this platform. This is just a couple of initial cases that we did. So here basically this dye is a 0.4% dye. So it is a higher concentration of trypan blue than the normal dye. We don't really use an air bubble while injecting this dye because the staining needs to be quite uniform. 2% sodium hyaluronate is the viscoelastic of choice, and a ring is used to support the eye because most of these cases are done under topical. That was the laser being fired, and we find that it's very useful to use a micro-rhexis forceps to just peel off the rhexis just in case of any tags as such. And then the phacoemulsification and the IOL implantation is as per usual. You can see this callisto overlay. So when the nucleus is actually still inside the eye, it is corresponding to the setting that we keep on the capsulotomy laser. So if you keep it at 5.5 and if we actually measure it post-operatively after the IOL is implanted, the rhexis comes down because there's nothing inside the bag which is keeping it inflated. So it seems like a smaller rhexis than what was planned. So I'm just going to show some of the interesting cases that we did using this laser. This is a mature intumescent cataract with a small pupil. Here you can see that this is the main indication for this laser. So we do have an access to a femtosecond laser as well. But the difference here is that the capsulotomy edges are rolled over. That's what makes the edges of the capsulotomy much stronger than even a manual capsulorhexis or a femtosecond laser. So this would probably be the primary indication to use this laser. It's much easier also for beginners to use it in intumescent cataracts. As Dr. Manpreet also explained, these dots are not the ones that need to coincide. The lines here need to coincide and form an inverted V. That's how you know that you are focused on the anterior capsule and not the cornea. After a few cases, when you have free-floating capsulotomies, you can even go ahead and directly do a hydrodissection. This is the routine phaco, so I'm going to skip ahead to the next case. This is again in a small pupil. Does it work with a Maligan ring? Yes, Dr. Kelkar did show a case with the use of a Maligan ring. The thing here is that you need to use a visco while implanting the Maligan ring itself. Initially, what happened was we just used a normal HBMC. So you can see how the staining happened. HBMC can never be fully removed from the eye. There's always some of it which is going to be stuck onto the capsulotomy. So you see the differential staining pattern here. It's not homogeneous, it's not uniform. So when the laser actually fires in a non-uniform staining pattern, there are some tags that are left and that have to be manually removed with the capsulotomy. So what we realized as a solution for this was that to insert the Maligan ring itself, we used a 2% HPMC, sodium hyaluronate, which comes out as a bolus when you remove the visco. And after removing the visco completely, you stain the capsule, you get a uniform staining, and then you go ahead with the laser. So ideally not to use HPMC in such cases. Of course, one of the major advantages of this laser is to use capsulotomy fixated lenses. We have been using the Femtis M Plus lenses in our practice, which gives excellent postoperative outcomes. And these lenses have to actually be attached to the capsulorhexis. It is a slightly more difficult maneuver and requires a higher skill level, but it helps when we have a strong capsulotomy because the capsulotomy does undergo some level of stretching when you are trying to implant the lens. Here you can see that after a few cases, you don't need to actually aspirate the capsule. You can directly go in with the hydrodissection because it's a free-floating capsule in most of the cases. Now the phaco as such is as per usual. You can see it's a dense cataract. This patient is planned for the Femtis M Plus lens. Looking at the implantation of the lens, it does require you to capture it onto the capsule with some maneuvers. And initially when we are starting off with this lens, we need to manipulate the capsule edge a little more until we get some practice with this lens. So you see it's implanted. And then some more visco is injected before we go in with a dialer and actually capture the lens on the capsulotomy. So some amount of stretching of the capsulotomy does occur, but the strength of this capsulotomy does prevent it from running off or having any significant weakness. The last case that I'll just quickly be going through is this traumatic cataract. Here, basically, it's a very soft cataract, but a CTR was used successfully with this case. Again, I'm not sure how to fast forward this video, but basically this was done under topical. The capsulotomy was done, a CTR was used, and there was some manipulation of the capsule edge and the bag, but it was easily and successfully done. I have even used this Femtis capsulotomy with the MyLoop device. Even with the MyLoop device, as you open the loop and you're encircling the nucleus with the loop, the rhexis margin does undergo minimal distortions, but a stronger rhexis margin like this definitely helps with such cases.
Dr. Supriya, you need to wind up. We are really
Yes,
running
sir.
short of time.
I'm done. Actually, this is a routine case with a CTR implantation. So that's it. I'm just going to end my talk here. Thank you for your patient listening.
Well, thank you very much. And the next speaker is Dr. Pooja, and she'll be talking about the OCT-based topographer and tips to enhance everyday practice. So the next few talks we'll be having on the OCT topographer, the MS39 machine, which is the new kid on the block for the OCT-based topography. Yeah, go ahead, please.
Thank you, and I would like to thank the entire My Healthscape team for inviting me here. So in OCT-based topographers, I'm sure we are very good experienced speakers here. So everyone's going to cover different aspects of it. So I thought I'll cover the epithelial mapping aspect in refractive surgery. So we do come across cases where you see an inferior steepening here, but there's no posterior elevation, maybe a little bump here, but otherwise fairly normal, and the biomechanics and all other parameters also look to be within normal limits. So why is there an inferior steepening? Are we looking at a case of a form thrust keratoconus, or is it like, but why normal biomechanics if it's a form thrust keratoconus? We do have multiple indices across different technologies who do tell us whether it's a healthy cornea or a suspect cornea, and for us to tell us that whether we can go ahead with refractive surgery or not. But are these indices enough for today's practice, or do we need something more? Now, what current topographers do is they measure the surface of whatever we see, but the true surface actually is the underlying stroma, because epithelium can be of any morphology, a regular or an irregular one, and that will actually mask the true surface of the cornea. So that is why we do need to look at the epithelium, and which is beyond what a Scheinfeld-based topographer will give us. So how do we solve this problem? The problem is so the answer is an OCT-based topographer, because it does give us an epithelial mapping and better information of the anterior chamber and the lens, and the repeatability of most of these corneal parameters is better than that of Scheinfeld-based imaging, and it has a faster scanning speed, and the repeatability is better in mild to moderate keratoconic eyes. Now, MS39 is nothing but it's a hybrid topographer, a combination of high-resolution spectral domain OCT with a placido disc-based imaging. And if, as refractive surgeons, we all know that many a times we do know that the placido disc imaging picks up those subtle cases in a very nice way or in a very superior way compared to that of a Scheinfeld-based imaging. So this is what we get, and we get accurate measurements in elevations, curvature, and power when it comes to the whole cornea. So MS39 gives us like all these parameters, the topographic and the tomographic data, epithelial and stromal thickness, and multiple other things, but I will focus on the epithelium and the stromal part of it. So how does it help us in differentiating from normal to suspect cases? Let's come back to the case. Inferior steepening, no posterior elevation, and the parameters look seemingly with normal range. So when we look at the MS39 mapping, you can actually see that the area of inferior steepening has an inferior epithelial irregularity, and the epithelium on the inferior zone is little thicker compared to that of the center zone. So yes, there is a little bit of irregularity, and there is no posterior elevation, and the stromal elevation is also absent. So that means it's a You see the inferior steepening because of the epithelial hyperplasia in the inferior region, and this is not a case of formfrous keratoconus, but a case of an ocular surface inflammation, and this is just an epithelial masquerade. So coming to the second case, this patient wanted refractive surgery, looks fairly normal, only the OSDS scoring is 12.5. And if you see the topography also looks seemingly normal, maybe a little small bump here, but otherwise fairly normal. Now, when we go to the epithelial mapping, the topography is normal, but it does show a little bit of inferior hyperplasia when you see the epithelial mapping. Now, why is this irregular? Are we looking at, are we just overlooking into this case, and should we just go ahead and do a refractive surgery, or should we investigate it further? So it is known that whenever you have a normal epithelium, your nerves are always going to be healthy. The corneal nerves, which is the corneal health is going to be healthy. The hemostasis is going to be healthy. But whenever there are a lot of epithelial irregularities and dendritic cells, that's when you get a irregular epithelium. And whenever you do a refractive surgery or any of such patients, or even if you do a cataract surgery or a smile surgery, post-op, these patients are going to have an aggression of the ocular surface inflammation. The epithelial remodeling is going to be quite erratic. It's not going to heal in a proper way, and that's when you have a poor quality of vision. So it's not just your surgery which is at fault, but if your epithelium to begin with is irregular and you just go ahead and do a surgery, post-op the patients may have a 20/20 vision but a poor quality of vision, and that is what you need to look at. Another which good feature it gives you is the epithelial, in addition to the epithelial mapping, you get the epithelial zernic also. So it's not just about the aberrations of the cornea anymore, you get an aberration of an epithelium. So if you look at this case, this is a very angry looking epithelium, and at the same time the sphere and cylindrical is almost 0.5, which is just coming from the epithelium. So again, the patient is unhappy post-refractive surgery, and it's not because of your refractive surgery, but an angry looking epithelium which is leading to all these aberrations, and that is why the quality of vision is poor. Now again, this is one more case, fairly healthy looking topography, looks fit for refractive surgery, no elevations, everything looks fine. But the epithelium is an O-shaped epithelium. Like if you see here, it's a normal topography, but it's an O-shaped epithelium. And Professor Einstein has clearly proven that even in a healthy cornea, if you see an O-shaped pattern, that may be an early sign of inflammation, and that can be an early sign what you see in the formfrous keratoconic patient or a keratoconus patient. So O-sign epithelium is a classic sign that you are dealing with something suspicious, even if the topography is healthy. And if you look at this case if you look at the stromal elevation, you can see that there is an early stromal elevation present. The posterior elevation is not present, but the stromal elevation is present, and that is why, yes, you are looking at a case of early formfrous keratoconus. So epithelium does give us a lot of answers, whether you are dealing with a healthy cornea, whether you're dealing with an unhealthy cornea. It may also help you predict how your post-op outcomes are going to be. And if you have an OCT-based topographer, if you get an stromal elevation, you can pick up these changes before even it's manifested on the topography. Thank you.
Well, thank you so much, Dr. Pooja. In the interest of time, we will move on. I would like to request each speaker to restrict themselves to 6 minutes, if possible, so that we can accommodate all the talks. The next speaker would be Dr. Vavikar, and he will talk about the MS-39 workhorse. May I request the other speaker to be ready with the computer on the other station? Dr. Adik. Thanks.
Yeah. Good afternoon, everybody. Thank you, Milescape, for giving me this opportunity. So, MS-39, a workhorse. Financial disclosures none, but I would like to mention Smith. Where is Smith? People from Milescape who keep on helping us in understanding the machine better. So nowadays is a time that we start combining two technologies. Over here, as Dr. Pooja has already explained, we are combining tomographer with a OCT machine. And this is all what it gives. To start with, this is what standard tomographer will give you, 4 maps. But as you go to the next screen, the fun starts. We know that epithelium does so many things. It's a masking agent. And therefore, it is important that we should be able to look at the stroma without epithelium. So over here, we have got stromal thickness, epithelial thickness, total thickness, as well as stromal elevation. And these are the patients where early form of keratoconus can be diagnosed. Normally, the epithelium looks like this, but these are all the different patterns epithelium can look like. And therefore, it is very important to understand whenever you are doing a treatment like surface treatment, like streamlight, where the epithelium is also removed with laser, whether this patient is a good candidate. For example, on left-hand side, this patient is not at all a good candidate for streamlight, whereas on the right-hand side, yes, we can go ahead with streamlight. Now, this is a case of dryness. You can see how angry the epithelium is. And this is definitely, if not treated properly, patient is definitely going to have lot of trouble. Then stromal thickness map, you can see that minimal thickness thing is displays inferotemporally, and it is increased in size. And you can see the stromal elevation, the tongue shape projection, which is coming from the left hand downside into the center, and this is definitely a suspicious case. Keratoconus screening is a very good tool which is available with MS39. On the top, we have got standard maps, anterior surface, posterior surface, and the 3 thicknesses. But on the in the second row, on one side we have got Gaussian distribution of posterior and anterior, which is basically for comparison of understanding how much the disease is progressing. Whereas the other 3 maps are showing pattern deviation, how much there is deviation from the normal pattern. Same thing holds true for the lower 2 graphs. Along with that, we also have a OCT image here, notable point spread, all the indices, and MTF. So in one nutshell, on one single screen, you know everything about keratoconus. This is one more example, and you are famous of this Krebs clause, PMD. This is another important screen where you get an understanding of whether the patient is progressing or not. We get as many as 25 points, 25 examinations can be compared, and we can choose which 5 to be compared. You can see that 5 elements are there, and first and the last map, the difference map is there, and it's very easy to understand whether the keratoconus is progressing. Now this is a case where intact version, you can see on the left hand side top, there is a sudden drop. That is the day procedure was done. Intact planning. Nowadays we have, rather than going always by the posterior corneal curvature, sometimes if there is too much of difference with the posterior and anterior axis, we do consider only anterior axis. And this is possible because over here you can adjust the incision site and placement of the intacts. And this is what the result is, excellent reduction in this thing. Zernike analysis, Dr. Pooja has already discussed, so I'll skip this. But it is very important that we understand what is the aberration profile of the patient, and it also gives you epithelium aberration profile. Now, this is a optical quality summary screen. Again, it's a very, very important screen when we are going for any, refractive surgery, when the patient is very, very demanding, this comes into play. Over here, on the left-hand side below, you have point spread function, then right side is MTF, and on the extreme right below is the actual values of the Zernike polymers. On the top, we have the aberration diagram, then the simulation of the visual chart, and what is the refraction patient is going to take. It is also possible to see the changes with difference in pupil. So for example, this is a patient who has got a pupil size of 2 millimeters. On the extreme left, you can see an excellent point spread function. But the moment pupil size increases to 6, you can see the point spread function has dropped and coma has appeared. You cannot see the numbers, but from 0.01 it has gone directly to 0.6. So unless and until we are thinking of something like Contura, is not a good candidate for simple refractive surgery. Pupillography has become very important. Nowadays we are getting very old patients for cataract who are interested in trifocal oil and their pupils are very small. And very young patients for cataract 48, 30, their pupils dilate like anything. And therefore, it is very important to understand how the pupil is going to play. Even if we say that most of the oils are not pupil dependent, that is not entirely true. Then angle alpha and angle kappa, everybody is aware of what is this? Biometry. This is another fantastic tool which is available in MS39. What we can do is that it will measure everything of the anterior by ray tracing technology. We just have to feed in the axial length and the calculation comes by its own. I'll take half a minute. Okay. So suppose you have a patient who has undergone LASIK and then ectasia and then C3R and then intacs. Then which formula going to use? Whatever you have done, ray tracing formula is always going to work because it is actually measuring the anterior and posterior corneal curvature. I'll go through this fast. OCT images, intacs, ICL vault, retained nucleus piece, DMD, double cut LASIK. There are 2 cuts of LASIK, first aborted, second completed. Epithelial bulle. Thank you.
Thank you very much, Dr. Vavikar. I would like to invite Dr. Radhika Natarajan for her talk, which will be on the use of anti-segment OCT in corneal diseases and corneal disorders. Dr. Radhika. Can I request the next speaker to be ready? Dr. Sheetal, are you ready with the talk? Thank you. I would like to request all speakers to just kindly try to knock off a couple of minutes, otherwise I think we'll not be able to complete the session.
We'll certainly
Thank
do,
you.
Dr. Hamid.
Thank you so much.
Thanks for having me over here, Mr. Munish and My Healthscape, and good afternoon to everybody. So I'm Radhika from Shankar Netralia. I'm going to quickly take you through some situations where the ASOCT and MS39 in particular have helped me in clinical diagnosis and treatment. I'm going to be dealing with the ASOCT part of the ensemble. We know it provides an optical biopsy of the cornea, and these are some cases where it has really helped me. This is a patient with a long-standing corneal scar who came with a central melt. Now, if it is well epithelialized, I need to wash, but if it is not, it's going to melt. Fluorescein will only pool. It won't tell me about epi defect. So the ASOCT over here, the MS39, has clearly shown me the continuity of the epithelium, showing me that it is a quiescent process and I don't need to do a surgery in an eye that is not seeing. So this is a case of infection, corneal infection, Mycobacterium keratitis. You see a smallish kind of infiltrate with hypopyon. The end-on view does not show anything beyond, and the side view also, the cornea is very edematous. I could not make out the endothelial exudate, but here the ASOCT clearly shows that it's actually reaching up to the lens where the arrow is pointing. It's a deeper infection than we thought, and that helped us further in the treatment. And with the medical management, you can see the resolution in the subsequent OCT. So these two corneal scars look very similar. One is a Rees-Buckler dystrophy, the other one is a Salzmann degeneration. But if you see the OCT, the first one, the anterior stroma is uninvolved, whereas in the second one in Salzmann, there is an irregular stromal scarring. So that decides the treatment, whether you want to do a PTK or whether you want to do an anterior lamella keratoplasty. So keratoconus, as has been pointed out, shows the donut type thickening of the epithelium. I'm not going to repeat that, but what I want to show you is that in an advanced case, there is an alteration of epithelial thickening overlying the cone, because there you have scarring and the thickening pattern varies, changes is what I want to show you. When this keratoconus progresses further, all topographers will fail you. You'll see blotches of red. You won't know how the keratoconus is progressing. But then if you do the OCT, you see disruptions in the Bowman's membrane. And if you closely observe these over a period of time, you know that the advanced keratoconus is advancing further or not, because then either you continue with the Pros contact lens or you opt for DALC as a procedure, depending on the progression. When it eventually breaks down into a high drops, there also we have this instrument which facilitates our management. You can assess the extent of the high drops and decide on putting the compression sutures, but that's not what I want to show you. Ironically, despite the high drops, the central cornea is very thin. So you need to know where to place the sutures. This patient underwent hexagonal compression suturing, and the results are here for you to see. And this is a single-eyed patient with keratoglobus, and the treatment for keratoglobus is usually a limbal sparing lamella keratoplasty. The patient gave history of injury. It was impossible to assess his Descemet's membrane. He was very photophobic and anxious in the single eye of his. And here the MS39 has shown multiple DMDs following the trauma. So an anterior approach keratoplasty alone will not help in this condition. And this is a patient with peripheral ulcerative keratitis. You can see extensive thinning in the periphery. So do you want to jump in and give immunosuppression to this patient? If you take a minute to see the MS39 picture, the area of thinning is wafer thin, but it is very well epithelialized. Again, the disease process is quietened over here. You don't need to immunomodulate this patient unless there is a recurrence of activity. So this crab claw, as has been pointed out earlier, may show that this is a PMD, but actually the map is a short one. It's an 8 millimeter map. So if you see the ASOCT, then you know that this is a pellucid-like keratoconus, whereas in an actual pellucid marginal degeneration, you see extreme peripheral thinning. So you can have a diagnosis at your hand. And here you see even before the cornea has decompensated, some amount of railroading and thickening of the endothelium, which is showing that this is a Fuchs endothelial dystrophy. And in the interest of time, I have multiple clinical cases like this where it's not been an ancillary tool but has actually helped me in the management. But what I want to conclude saying is that not only in these clinical patients, MS39 and other OCTs, I have a fair share of other OCT pictures also, have helped us a lot in substantiating our findings in all of these publications as well. So I'll be most happy to take outside this hall to whoever is interested the sharing of the other cases where this device has helped me in management and treatment. I hope I complied with your request.
Fantastic images and wonderful presentation, I think, Dr. Radhika. I would like to request Dr. Sheetal now, and she'll also be talking about the MS39 and all-in-one refractive workstation.
Thank you so much, sir, and good evening,
Thank
everyone.
you.
I'll be talking briefly about MS39. Most of the technology part and its applications have already been covered by previous speakers. So I'll just briefly talk about the technology, and I have been using this since past 3 or 4 years, and it has been really helping me in my practice in improving my decision making and also evaluating the results of refractive surgery. So this is the most advanced device for analysis of anterior segment as of today, because it combines two technologies, the Placido disc corneal topography as well as a high resolution OCT based anterior segment tomography. Now it's a spectral domain OCT with a wavelength of 845 nanometers. Its resolution in air is 35 microns and in tissue 3.6 microns. Now basically if we look at the differences of MS39 from Pentacam, of course technology, the area mapped is much wider, 16 into 16 versus 9 mm. The points measured are also more, 36,000 odd points on the anterior cornea and 26,000 points on the posterior cornea, whereas Pentacam measures about 25,000 points on the anterior cornea. So curvature maps are directly derived from the tear film and anterior corneal surface. In the Pentacam, curvature maps are derived indirectly from elevation maps. What is available in MS39 and is not available in Pentacam is the epithelial thickness measurement, the stromal elevation and thickness map, optical quality analysis, OCT, corneal and angle section, tear film analysis and dynamic pupillometry. So keratoconus screening is very convenient to do. So what it gives you is basically notable point spread function. Now this is very easy to diagnose keratoconus through this. So basically you see the value of NPS. Normal value is more than 1. If it's borderline keratoconus, the value is within 0.6 to 1, and if it's keratoconus, it is less than 0.5. So it also gives you Gaussian curvature curves, which are thought to be more sensitive and depict true morphological picture of the pathology. So this essentially is derived by the mean of maximum and minimal curvatures at one point at the surface. Now if you see, this is a summary of a particular eye with keratoconus. If you just see the anterior and posterior surface, the regular maps, the size of the pathology is a particular size, and if you just see the Gaussian maps, which is just under these, so you can see that the keratoconus is more on the anterior surface than on the posterior surface. So it actually gives you a better morphological depiction of the pathology. Keratoconus progression has been already covered, even the epithelial thickness. Now I'll just show you few cases where this equipment actually helped me in better decision making in deciding which patient to operate or not for refractive surgery. Now this is pentacam map of a patient who has a low myopia, very low myopia. It's a thin pachymetry, 458 microns with a FFKC-like picture on bad display. Now in these cases, you would be very worried and probably will not want to do refractive surgery or would go for ICL or something else. But when you see this map, the same patient's map on MS39, because it considers epithelial thickness profile as well and the Gaussian maps, etc., it has actually given me the report of normal. And since it is normal, I can probably go ahead with a PRK in this case. Another case with a thick cornea, FFKC-like picture on bad again. So again here, because the epithelial maps and everything is normal, I can probably go for a PRK or smile extra in this particular case. Advanced analysis of tear film, you don't need to do any of those invasive tests, Schirmer's 1, 2, and which is uncomfortable for the patient and also very subjective. So it gives you NIBOT, which is the non-invasive breakup time, and this is what we have been using for our refractive patients. And you see how it gives you the report is all the dry spots are highlighted as hot colors, and in this particular patient the NIBOT was quite low, around 5, and when we treated the dry eye, you can see that it has improved to around 15, and the astigmatism, which was 1.5 and 1.8 earlier, is now reduced to 1 and 1.2. So optical quality analysis has also been covered, also the corneal abrasions. It segregates epithelial abrasions from the total corneal abrasion, so you know the source of the abrasions as well. Dynamic pupillometry is very important, especially while planning refractive surgery. Your pupil size, the optical zone, etc. It gives you pupil size in different light conditions, scotopic, mesopic, and photopic. And another thing that we have been using this for is to do the dynamic vault assessment post ICL or phakic IOL. So you can see that when the pupil goes from a scotopic to photopic condition, and as it constricts, the vault reduces. So that is the actual representation of the vault, which is the dynamic vault, which should ideally be studied. So you can see in this particular case, the scotopic vault was 266, but in photopic condition, it reduced to 227. So actually that is the vault which you should be considering. It also has advanced lens biometry, and you can use this for IOL power calculations as well. And I particularly find it very useful for post-LASIK cases, because this tool is basically based on the ray tracing principle, and it gives fairly accurate and comparable results with the Barrett, TrueK, TK, all those advanced formulae. It can also be used for intrastromal ring segment planning. This is a case showing ICR in situ. So in conclusion, MS39 has multiple useful functions for a refractive surgeon to enable an anterior segment surgeon better understand their patient's visual needs and requirements and choose the most appropriate course of action to address them. Thank you so much for your attention.
Well, thank you so much, and I would like to now invite Dr. Geeta, is not there. Dr. Geeta, please, for a talk on role of anti-segment OCT in corneal and ocular surface disorders. Dr. Geeta, please.
A very good afternoon to one and all of you. We've seen the various uses of MS39 in different aspects of refractive and corneal conditions, and what I will focus upon is on the role of the AIOCT in ocular surface disorders. Can we have the screen, please? So we have understood the various aspects of AIOCT and the role of AIOCT in various conditions in the cornea and ocular surface. In ocular surface disorders, it's primarily with respect to decision making, especially when you are planning surgeries in these patients. Dry eye, there is a definite role with respect to TMH, the tear breakup time, and especially the scleral lens fitting, which has already been focused upon. And I'm going to take you through one specific area here, which is ocular surface tumors, where MS39 has a significant role to play. Before we go into the ocular surface tumors, in ocular surface disorders, well, when you have to decide whether you're doing a limbal stem cell transplant with or without a corneal procedure, whether lamellar or penetrating, ASOCT has a definite role to play in terms of understanding the status of the underlying cornea, the presence of thinning, the presence of scarring, which will tell you whether you need to combine your ocular surface reconstruction along with a lamellar or a penetrating keratoplasty, and that is where it has a very, very important role to play in these ocular surface disorders. Ocular surface tumors will form the mainstay of my talk, and we all know that in ocular surface squamous neoplasia, the classic triad of hyperreflective epithelium, increased epithelial thickness, and an abrupt transition between the normal and the abnormal epithelium is what helps us to clinch the diagnosis in cases of OSSN, as you can see here. More importantly, with the advent of topical chemotherapy, ASOCT helps us to understand the resolution of the lesion. As you can see here, with 2 cycles of topical chemotherapy, there is a significant resolution and normalization of the corneal epithelium following the onset of topical therapy. This is another serial clinical as well as ASOCT pictures which show you how the lesion resolves and the role of ASOCT in helping you come to an understanding as to when you would need to stop the topical therapy in these patients. This is a patient of corneal OSSN where you can see the significant thickening of the corneal epithelium and the complete normalization of the epithelium over 3 years of follow-up, showing no evidence of any recurrence. So this is again a serial ASOCT picture of the same patient. Here again you can see how serial pictures with topical chemotherapy starting from June 2022 with multiple cycles of topical therapy shows a complete normalization of the epithelium, and one cannot underestimate the role of the ASOCT when you're treating these patients. Again, it helps you to understand whether there is what the depth of the lesion is, whether there is scleral involvement, because your management in patients of ocular surface tumors changes when you have an involvement of the underlying sclera. It also helps you to monitor these patients post-treatment and helps you pick up an early recurrence when there is a thickening of the corneal epithelium, and when you are in doubt, it is best to do an ASOCT where you get a classic feature of the recurrence and you can restart the treatment in these patients. We know that pigmented lesions are another important aspect of ocular surface tumors, especially the conjunctival nevus with which a lot of children present, and ASOCT again plays a very important tool here in helping us document and follow up these patients to monitor any change in the size or depth of the lesion. It also helps you to clinch the diagnosis of nevus by the presence of these classic cystic spaces that you get in these nevi, and this is a serial follow-up of the same child over a 2-year period where you document stability of the lesion and therefore decide just to observe these patients. So these are different ASOCT as well as clinical picture scans of patients with pigmented lesions where ASOCT has a definite role to play. Apart from nevus, the other pigmented lesions that we see are PAM and melanoma. With the PAM, it is an absolutely flat lesion without any cysts, unlike your nevus and your melanoma, and it is just a hyperreflectivity of the basal epithelium that you see in these patients. Pigmented lesions always tend to have a backshadowing, and when you're dealing with a thick lesion like this where you're suspecting a melanoma, this is probably one limitation of the ASOCT where you cannot image the deeper aspect of the lesion and therefore would have to probably depend upon UBM to understand better the deeper aspect of the lesion. Lymphoproliferative lesions form the third most common lesion that you see in ocular surface tumors, and this is a patient that we recently operated upon with a salmon pink patch in the conjunctiva. And when you suspect a lymphoproliferative lesion and you get the ASOCT done, contrary to your OSSN, these are classical subepithelial lesions where the epithelium is absolutely normal in thickness and the subepithelial lesion has a more homogeneous hyporeflective texture on the ASOCT. And you can see serial pictures over a period of 6 months, the lesion has actually increased, and this patient underwent an excision biopsy, which is the only way of clinching the diagnosis in these lymphoproliferative lesions. Again, some more examples of these lesions. When it's very large, you will have to fall back upon UBM. And one differentiating condition from lymphoproliferative lesions or thickening of the sclera is you need to rule out scleritis, where it will actually show you a thickening and edema of the sclera, unlike the lesions that I showed earlier. So just to sum up, some examples of a cystic lesion where ASOCT has a role to play, the pterigem and pinguicula, which was already discussed, and this is just a algorithm about the different conjunctival lesions that we see and how we could utilize ASOCT as an important tool and a very, very important adjunct in the diagnosis and management of these lesions. Thank you.
Thank you very much, Dr. Geeta. And very short presentations now. Dr. Rushad Shroff, kindly make it very short. Chintan, kindly be ready on the other side. Could you just highlight how does CASIA-2 help in diagnosis?
So thank you, sir, and I'll make it a T20 match as quickly as I can. So the resolution of this OCT is very, very good. I'll just skip ahead to basically one example that I'll just put across here where we actually had the machine was very useful. So IOL power calculations in ectasias are very difficult, and generally you're a little worried about what power you're going to implant in these patients, and that's where I think the OCT and the IOL power calculation from this is very, very helpful. You can feed in the various formulas. You can see the Barrett true K was used in this particular example, and according to that, that's where we got the IOL power from. So this is a 48-year-old female with RKs done using contact lenses, no other relevant family, past and systemic history. The visual acuity in the right eye was 624 improving to 6.9. The left eye was 3/60 improving to 6/15. 16 RK marks, NS2 to 3 cataract with myopic fundus changes. So you can see here the axial power map shows an irregular kind of cornea in the center, and this is basically the printout showing the axial, the elevation, anterior, posterior, and the pachymetry. And this is the OCT image of the same patient. When we put this into our TOMI calculator, we are not getting an IOL power, and that's concerning because generally the biometer does very well and manages to calculate in most patients. And the IOL Master 700, we did manage to get a power which is showing about 18 diopters for emetropia, and the ASCRS calculator was also showing about 18 diopters. When we put it into the CASIA-2 system with the Barrett 2K, we were getting about 16. And we actually went ahead and we've done a series of patients like this. We implanted with the iHance EDOF 17 on the box. The post-op vision unaided on 1 week was 6/15, 2 weeks was 6/9. The patient was quite happy with this. So I would just like to reiterate that in these kind of corneas where where the Steinflug may go wrong or you may have issues regarding your IOL power calculations, this machine actually helped us and helps us continuously take good decisions. So with that, I'll just end. Thank you, and thanks for the opportunity.
Thank you so much, Dr. Rushad. I think very interesting what CASIA-2 can do for us. Chintan, if you could just highlight the role of CASIA-2 in lenticular pathologies in a very short time. Dr. Chaudhary, could you please be ready on the other podium? Just to have highlights of your talk, please. Thank you so much.
Thank you, and I will try to be as short as possible. So I'll be talking about how it shows lenticular pathologies, and I'll be talking about morphology in particular. Since it's a swept source OCT, it scans deeper and it scans wider, and one is able to see the posterior capsule, and which is how it helps in seeing the posterior capsule. It helps in seeing the lens contour and the lens and the IOL tilt. In white cataracts, it's especially useful because depending on the morphology, if I see a cataract which is solid with no fluid, I'm happy to go ahead with the single stage capsulorhexis. If I see a cataract which has fluid anteriorly, I would like to go for needle aspiration without a prior, which will decrease the risk of a runaway capsule. On the other hand, if I see swollen fibers anteriorly and lens fluid cavities posteriorly, in that case, I would like to go ahead with a forceps-assisted two-stage CCC or a femtocapsulorhexis. It's very useful in posterior polar cataracts, one, to see the morphology and to see the involvement of the posterior polar cataract. And in brief, it's been shown that it has a 100% sensitivity and 100% negative predictive value. If a PC rent is there in a posterior polar cataract, it will show up, and if it's not there, then also it will show up. In traumatic cataracts, again, the same thing, because the posterior capsule can be imaged. This is a case of an iatrogenic trauma. This was a patient receiving intravitreal steroids presented with a cataract, and you see the breach in the posterior capsule so beautifully, and you can plan your surgical plan accordingly. Detecting changes in lens contours, subtle lenticonus may sometimes be missed. This is a patient detected to have anterior lenticonus. Once you see this on ASOCT, and then you can go ahead and this patient was later on detected to have Alport syndrome, and sometimes, this can be life-changing for the patient. White reflex in the pupillary area in a patient having undergone cataract surgery. And I'm not saying this is the American Academy saying this, that this has been mistaken for a posterior capsular opacification, IOL glistenings, capsular bag distension, and vitreous hemorrhage or haze. So you look carefully. If only the anterior and posterior surface is opacified, it's an IOL opacification. If it's within the lens, it's IOL glistenings. If it's behind the lens fluid, it's capsular bag distension syndrome, and the management of each of these is different, right? And the last is the evaluation of the IOL tilt. This was a patient implanted with a CMT flex for aphakia. Vision, however, improved only to 636, and there was pigment dispersion on the IOL. And one can see how beautifully this is showing the tilt of the IOL, and which is rubbing on the iris and showing the posterior, which is why the pigment dispersion was occurring. To summarize, I'll just finish here. The CASIA has the IOL cataract surgery. Frankly, Dr. Rushad has spoken about it. We've not been using it for that purpose. It doesn't yet measure axial length, so it's not a complete biometer in that sense, and we haven't been looking at it from the point of view of managing the power in cataract surgery patients. Thank you very much.
Thank you, Chintan. We move on to the penultimate talk, which is Dr. Urvaja, and she'll be talking about different case scenarios with CASIA 2.
Silver ion-based self-preservative technology, and there are various preservatives in the eye preparation such as quaternary ammonium compounds, oxidizing agents, ionic buffers, amidines, parabens, alcohol, and the ones which are mercury-based. But there are also several articles which have highlighted the fact that these preservatives can have deleterious effects. So the need for preservative-free eye drops is definitely there, and this is known to all of us, especially in cases of moderate to severe dry eye. And this is unusual, and this is also known very well that silver is known for its biocidal properties and exhibits the bactericidal, fungicidal, and virucidal properties. And the biological efficiency of silver nanoions is higher due to high surface to volume ratio. So nano-silver ion-based antimicrobial technology is what is used in these drops, and the features of the nano-ion-based technologies, wide spectrum of antimicrobial activity, and the fact that it is non-corrosive. Now, if you look at the So this is just to show that the nano-silver ions do have antimicrobial actions at all levels, even at the cellular level, and that is why it is useful to have this, especially in your bottles. And there are two ways of testing: the antimicrobial efficacy testing and the microbial in-use study. And the antimicrobial efficacy testing helps to this testing was done to demonstrate the antimicrobial efficacy of the Lubi-Moist eye drops, and microbial in-use study was done to evaluate the efficacy of the Lubi-Moist eye drops. So the limits for the ophthalmological solution products are given both in US and Indian pharmacopoeia, and basically if there is 1 log reduction, that means there's 90% decrease in the microbial growth, and if there's 3 log reduction, that means there is almost 100% decrease in the microbial growth. So the organisms which are looked were Candida, Aspergillus, E. coli, Pseudomonas, and Staph aureus. And the brief methodology is, the brief methodology is which is shown here. That is these are the observations of the antimicrobial testing that was done. And for the log reduction at 7 days should be for E. coli, Staph aureus, Pseudomonas aeruginosa, Candida, and Aspergillus. The acceptance criteria for 7 days is 1 log reduction, and for 14 days is 3 log reduction. And if you see the table, these values are all much more than this. And likewise for the other, for log reduction at 7 and for 14 days as well. So to combat any microorganism during the use of the Lubimoist eye drops, the efficacy of these drops was also studied, and this of course met the acceptance criteria which is given by the pharmacopoeia. And the study was divided into two parts: the in-use or whole time study and the in-use microbial challenge study. And again, in this, these are the observation of the microbial in-use study, where there was no, where total yeast and mold count as well as the total aerobic microbial count was evaluated, and it was found to be nil at all days, including 10 days, 30 days, as well as 60 days. These are again the observations of the microbial in-use study, where microbial strain was added to these bottles, and it was again found that at 10 days, 30 days, and 60 days there was no growth which was present. So the summary of the microbial in-use was that 3 or more than 3 log reduction at 10, 30, and 60 days there was nil growth, and Lubimoist eye drops with nanosilver ion-based self-preservative technology showed significant amount of efficacy. The toxicological studies were also done, where 2 types of studies were done, where systemic injection was done in the animal models and intracutaneous reactivity test was also done. And it stood the test of both the tests, and in this Lubimoist that is present, there are no leachable impurities. The silver ions, they remain encapsulated from inside the container. It is non-toxic to the ocular tissues. It is cost-effective and has broad spectrum of efficacy against the various microbes. Thank you very much for your kind attention.
Thank you. With the we have the last talk now. Just very quickly, if you could just sum up the highlights of your talk, and
I
we'll
have
wind
only
up.
the highlights,
Thank
though.
you.
Thank you very much. Thank you, my healthscape. Thank you, Mr. Monish. These are certain case scenarios that I would like to present with CASIA. It's a very beautiful tool with a good resolution, 16 mm scans, swept source OCT, where it helps in cornea cases especially to decide between the depth of scarring, the dystrophies, and decide you between selecting between KPs and anterior lamellar keratoplasties. It helps in you other lamellar keratoplasties like DSEC in assessing your post-operative complications, your progression, to monitor your patient follow-ups, where this was a patient with DSEC. After rebubbling, especially in cases of keratoconus, it works very well. Like here, this is a case of keratoconus, severe keratoconus, and you can see the epithelial hypertrophy in the center. So just on the topography, it will give you a very good thickness, but if you see on the anterior segment OCT, the stroma is actually very less. So it won't help you with the cross-linking, and here is when you need to take a chance whether this patient should be converted to a keratoplasty or can be continued on scleral lenses, and cross-linking is definitely not the choice. CASIA also gives you a very good epithelial mapping on the down right of the both the maps. You can see there is a concentric epithelial donut pattern being formed. These are all the cases of keratoconus. In very early keratoconus also, these kind of concentric thickening can be seen, and this actually helps you in assessing the keratoconus progression, assessing the epithelium, because epithelium tends to mask the stromal steepening, and it will mask the keratoconus progression by compensating the steepening. So just assessing the epithelial mapping can help you in assessing the progression. And in very subclinical kind of cases where everything looks fine on 4 maps, on BAD-D, on other topographers also, if you just assess the epithelial modeling pattern, the donut pattern, it is very much diagnostic of subclinical KC, and you can prevent a lot of cases of post-LASIK ectasia. This is where I find anterior segment OCT epithelial mapping very, very, very useful. Now this was one very interesting case. A young lady presented with pain, sudden diminution of vision, swollen eyelids, all features of angle closure glaucoma, high IOP. On ASOCT, we did an ASOCT and found that the lens thickness was increased and the angles were very narrow. On B scan, we saw a ciliary effusion. And on taking a history, we found that she was on topiramate for headache. So the topiramate was stopped and all the anti-glaucoma medications were started for her. She improved the second day little, and we saw there was a myopic shift due to the ciliocoroidal effusion. Anterior displacement of the lens iris diaphragm was the main cause for the myopic shift and the angle closure. And she improved within 3 days. The thickness reduced, angles opened up. By day 7, anti-glaucoma medications are completely stopped, and she was shifted on low-dose steroids. And by 1 month, she came back to 6/6 vision. These were again 2 more cases of topiramate-induced angle closure. So anterior segment OCT helps you find where the problem is, where the etiology is, and it clearly, mostly it helps in explaining the patient. You can counsel your patient, and the compliance of the patient increases if you tell them what the problem is, and it will increase more if you show them what the problem is. So AS OCT helps you very well to for adherence of the treatment of the patient. This is a case of Descemet's membrane detachment diagnosed on AS OCT, a case of posterior capsular integrity. Preoperatively, one is the posterior polar cataract, other is the traumatic posterior polar dehiscence. So when you know this beforehand, you're very well prepared in your OR, what you're dealing with, and you can prevent complications. You can be prepared beforehand, what all things you need to, and you can counsel the patient. This also helps you in phakic-IOL monitoring, the vault assessment. It also helps in assessing the epithelial map. This was one case from operated overseas, done LASIK. He was again done a PRK, followed after that. We had no history why the PRK was done, as patient said that he had some residual power and PRK was done. Now he is again complaining of disturbed vision. So we see that there is a simulated image and a lot of aberrations. So, but we do not know if the PRK was done, whether flap lifting can be redone for him. He was getting troubled since 2 years. So that's where the AS OCT helped us in knowing the epithelial thickness, and we knew that now the epithelium is fine, so we can relift the flap and do the treatment for it. And patient really improved a lot just after the topo-guided treatment. It helps in customizing scleral contact lens fittings for the beginners. It reduces the time, precise fitting, and it's very good for the beginners to understand how the scleral lens fittings are done. This is one case of Brown-McLean syndrome, a case of post-traumatic dislocation, sclerolimbal cyst, glaucoma. Mostly I would like to say that is a very beautiful tool. It helps in giving confidence to ourselves what you're dealing with, so that confidence can be imparted to your patient. It helps you tracking the response and patient education and counseling, therefore a better compliance. Thank you. Thank you.
Thank you very much, and I would like to thank all the speakers and who have curtailed their short talks for the duration of this session. I would like to thank Professor Jagatram and the whole team who is coming in for being patient with the delay in this session.